As we enter the final module of this course, we shift from understanding systems and programs to examining a deeper question. Who benefits from these systems and who does not? Throughout this course, we've discussed economic policy, Medicare and Medicaid, community supports, communication, cultural competence, and program development. But designing effective programs is not enough. We must also ask, are these programs accessible to all older adults? Do they address longstanding inequities? And do they reduce disparities or unintentionally reinforce them? This is where the concept of health equity becomes central. Health equity in aging is about ensuring that all older adults, especially those from historically marginalized or underserved communities, have a fair opportunity to thrive. Let's begin with definitions. Health equity is often described as the absence of avoidable and unjust differences in health across populations. It is important to distinguish equity from equality. Equality means providing the same resources to everyone. Equity means providing resources according to need so that outcomes can be fair. In aging, this distinction matters deeply. If one group of older adults experiences higher rates of chronic disease, lower wealth accumulation, and reduced access to care due to lifelong structural disadvantage, then treating everyone the same does not produce fairness. Health equity requires acknowledging differences and responding intentionally. In the article, Reducing Health Inequalities in Aging Through Policy Frameworks and Interventions, McGuire emphasizes that health inequities in aging are neither random nor inevitable. They are socially produced and therefore socially modifiable. We cannot fully discuss equity without acknowledging health disparities in aging care and elder outcomes. In the US, health disparities in older adulthood are stark. Focusing just on racial and ethnic disparities, in the US we see that life expectancy varies significantly across racial groups. Chronic disease burden is higher among historically marginalized populations, and access to high-quality long-term care differs by race and income. These disparities reflect decades of structural inequality, including segregation, discrimination, and differential access to education and employment. Beyond race and ethnicity, there are also stark socioeconomic disparities. Income and wealth disparities widen across the life course. Older adults with lower lifetime earnings are more likely to experience housing instability, food insecurity, limited access to health care, and reduced retirement savings. And as we can infer, financial insecurity also compounds health risk, as those with fewer financial resources may have more limited access to needed health care, even with the support of Medicare or Medicaid. And we can't discuss disparities without also talking about gender. Women live longer on average, but are more likely to experience poverty in later life, live alone, serve as caregivers, and have lower retirement savings due to wage gaps. Each of these contribute to the experience of aging. To wrap up, though, we should also reapproach a concept we've discussed previously: intersectionality. Health equity cannot be understood in single dimensions. An older woman of color living in poverty faces compounded structural disadvantage. Intersectionality reminds us that aging is experienced differently at the intersections of race, gender, class, disability, and sexual orientation. McGuire argues that to address health inequities in aging, we must confront structural drivers, including structural racism, policy bias, and ageism. Let's very briefly go through each of these. Structural racism shapes residential segregation, environmental exposures, school quality, employment opportunity, and healthcare access. These factors accumulate across the life course, producing unequal aging outcomes. On policy bias, public policies may inadvertently reinforce inequality. For example, means-tested programs may require asset spend-downs that destabilize households. Long-term care policy historically favored institutional settings over community-based supports. And complex eligibility systems disproportionately burden those with fewer resources. Yes, policy can be dry, but it isn't neutral, and it shapes opportunity structures. And then finally, let's once again address ageism. Ageism intersects with racism and sexism. Underinvestment in geriatric care, stereotypes about older adults' capacity, and dismissive attitudes towards older populations influence funding priorities and care quality. Health equity in aging requires confronting ageism as a structural force. Earlier in this course, we discussed the life course perspective. Health inequities in later life often reflect cumulative disadvantage. Disparities in education, income, employment, environmental safety, and healthcare access begin early in life and compound over decades. By the time individuals reach older adulthood, these accumulated exposures shape disease risk, functional limitations, financial stability, and social support networks. Health equity in aging cannot be separated from early life policy and structural conditions. In their chapter, The Role of Public Policy in Meeting the Needs of Diverse Aging Populations, Meyer and Fraser emphasize that public policy plays a critical role in meeting, or failing to meet, the needs of diverse aging populations. Policy decisions determine funding allocation, program eligibility, service availability, and regulatory standards. Some programs are universal, like Social Security. Others are means tested, like Medicaid. Universal programs may reduce stigma and increase participation, but may not fully address disparities. Targeted programs can focus resources on those with greatest need, but may create administrative barriers. The challenge for policymakers is balancing universality, targeting, adequacy, and sustainability. And we can't really talk about equity in public policy without also talking about the social determinants of health. As a reminder, social determinants include housing, transportation, nutrition, social connection, neighborhood safety, and access to culturally competent care. Programs that ignore social context cannot achieve equity. For example, an older adult may have Medicare coverage, but if transportation is unavailable, access to care remains limited. Or a caregiver may qualify for respite services, but if funding is inadequate, the service may not be available locally. Equity requires cross-sector collaboration. Equity cannot be improved without measurement. This requires disaggregated data by race, ethnicity, gender, and income, transparent reporting, accountability mechanisms, and community engagement in program design. Health systems and policymakers must ask, who is not being reached? Who experiences worse outcomes? And why? Again, equity must be intentional, not assumed. Health equity is not merely a policy preference. It is an ethical obligation. The principle of justice requires fair distribution of resources and opportunity. For professionals in gerontology, this means designing programs with marginalized communities in mind, engaging community stakeholders in decision-making, and recognizing structural barriers rather than attributing disparities to individual failure. Health equity in aging is about fairness across the lifespan. This lecture connects directly to themes from across the course. The demographic transition shapes population-level needs. Sociocultural and structural forces shape aging experiences. Economic policy affects retirement security. Medicare and Medicaid shape access to care. Community-based supports influence quality of life. And communication practices affect dignity and inclusion. Health equity is the thread that ties these together. To summarize, health equity in aging means ensuring that all older adults, regardless of race, income, gender, disability, or geography, have a fair opportunity to achieve well-being. Disparities in later life are not accidental. They reflect structural forces across the life course. Policy can reduce inequity or reproduce it. As we move into the next lecture on strategies for promoting health equity, consider this question. If we truly designed aging policy around health equity, what would look different in our communities? This concludes the first lecture for Module 8. If you have any questions about the material covered in this lecture, please contact your instructor for this course. Thanks for watching.